So, Johnny Owens.
Johnny O.
Johnny O is on the show today.
Then start watching. I don't know what the hell you're listening
Yeah, I
to.
know.
I feel like right now blood flow restriction is one of those things that if someone mentions it, they kind of got an idea about it. So it took about 4 years for it to be from the ground level.
Yeah. I mean, people would look at you cross-eyed when
I
you first
bet.
talk about it.
I bet.
We used to see my surgeons when I went and talked to them, they're like, "You're on crack, Johnny, really?" And so they're like, "Did you vet this with the command?" And so
Is that the same room with the people with the penis tourniquets on?
yeah, you're right. You've been hanging out with the ISR game with the penis tourniquet guys.
It's a weird room, Johnny.
yeah.
I don't know about that room.
Yeah, it was. I mean, you would tell people, and they just look at you. And now, I mean, people are like, now everyone's like, "Oh, I've been knowing about this forever."
Yeah,
you know, this
yeah,
sort of thing. But
yeah.
it's good. It's definitely becoming more mainstream.
I'd love to get your opinion and your perspective on the difference between showing up at your standard orthopedic clinic with your mother-in-law doing quad sets at a standard clinic versus you doing limb salvage and working heavily with the military. And what's the mindset compared to your standard orthopedic patient versus I have a Marine or somebody from the military, and this is maybe a more serious injury or potential that I have to get them to.
Yeah, and every injury is serious to every individual. You know, everyone deals with them differently. Some of our, high level, high amputees, the way they handled it better than maybe someone, with an ACL or something like that. So, I mean, injuries, they all affect people in different ways. But one thing I would say is I was very, very lucky to work at the DoD during a time of war. And it's terrible what war has done to our service members. But the way that everyone came together as a team, and it's a true team thing. You hear people throw that around, but I mean, it's from orthopedic surgeons to nurses to command to PTs to everybody, to the soldiers' families, to the commands of their platoons. Everyone was just looking for a solution. There was no bullshit, and there was no like, I'm going to call the doc and they're not going to answer me. Because if you ever got that, then it'd be like, I'm going to call, my colonel or the commander, and they're going to be like, dude, what the hell? We got this kid. We got to figure out
Yeah.
And so that was amazing to have that true team feeling. So you would get a Marine or a service member. You get a manifest. This is like maybe during the surge when it was really, a Humvee would get hit, and you would have, 6 guys all coming in, amputees, limb salvage, maybe 2 killed. We would all kind of come as a group and meet up with them, meet with the family, usually try and meet them an inpatient and discuss, these are the options. You're going to keep the limb or not going to keep it. Bring some other soldiers that have gone through it to meet with them, and then get them there. And it was on, and it was basically do everything we can to get them to the highest level. The highest level for a lot of them would be to stay on active duty even after they had been blown up, and that was the goal. And it's like, okay, man, if you want to be a trigger puller, you got to be able to get down, take a knee, hide behind a rock, and do this or that. Or if not, then it was to at least try and get them to the highest level that they are discharged with a functional life. And then it became, with the limb salvage, how can we avoid that they have to amputate when they might not want to? Yeah, it was an amazing time. It was really, I was blessed. I just lost one of my guys last week.
Sorry to hear that.
Yeah, from an infection in his bone that spread up and kind of got worse throughout. But I mean, it's almost 10 years later, and so it's the wounds of war. They're still there, and we got to remember all these kids that are fighting every day with what they did for us.
Yeah. I'd like to get your advice for any students or young therapists coming up. I think Tyler and I were pretty jazzed.
Jazzed up, baby.
We're jazzed up, baby. I'm definitely would like to follow in your footsteps. As generally speaking, your philosophy on how to treat people, how to interact with, how to play as a crucial team member to somebody. I'm definitely in love with that. The whole, for a military individual, we have a whole team around them, and it's a mission to get this person better, as opposed to like some stories we hear in other settings where you feel more isolated from the healthcare team.
Yeah.
And it's like, oh, I'm trained in this, and I'm set in my ways, and I don't know why I did a manual thing there, but no disrespect to manual thing.
Or you were doing CPR.
Yeah, that's what I was doing. So any advice that you have for us to be like Johnny?
No, man, I don't know if you want to do that, but I got lucky. My first sports med gig was with some great orthopedic surgeons, and they really kind of took me under their wing. And we talked about this before, that it was our journal club. I had to go drive to the library because of the internet. There wasn't even PubMed or anything, and work all hard to find a journal and bring it back. And it became, you really took deep dives, and it wasn't just, I learned a little bit of this, a little bit of that. It was, man, I'm going to learn this. I really got into it. And these surgeons were also great, and I really started to feel like their peer, and they treated me like that. And so I think if you can, get the healthcare team to all, we always say, check your ego at the door whenever you walk in. That's helped me a ton. And from this point on, I think that's where PT needs to have itself. Now we have to do things, again, that are well respected. And if we're doing a bunch of stuff that just doesn't make sense or is willy-nilly, we're not going to get that from them. So I think getting our respect level up, that what we're doing is very valuable, helps a ton. And I would definitely try and value yourself well. And to do that, then question everything you do, And so if you're doing something, don't just do it for the sake of doing it. Yeah. And with everything in life, but with PT, I mean, even your treatments that day for the patient.
Mm-hmm.
They've come in, they've worked hard to get there. I had a guy one time and I was all kind of pissed off about some other, my 9 millionth meeting of the day that the DOD had me go through. And he's like, "What's your problem, man?" He's one of our amputees. And I was like, man, blah, blah. And he's like, "Did you know it took me 2.5 hours just to get dressed and get the bus and get over here?" And all. And he's like, and then you hear that and you're like, man, I'm going to give this guy like the best treatment I can today and do everything I can. If I don't understand something to help him, I'm going to really work on it, or I'm going to be at least smart enough and good enough to tell him, like, I don't think what I have is going to help you. And that's I think some PTs just, you get this burnout because you just keep trying. I don't know, I'm trying and you have to be able to be just upfront lots of times too, like, look, no, this isn't going to work, or what they're telling you over there is bullshit. That's not going to work. Yeah. This is just what it is, and let's move on and see what we can do to help you at this next level. We don't heal everybody, and we got to get over that. And there's always also this worry that, like, man, there's probably someone else that would be able to get this person better, right?
Yeah.
And I think that's part of our problem too, is we're just so scattered of what our profession is. It's just like, well, these guys are all doing this thing, and these guys are all doing this thing, and they're saying that they're getting these people better, and they're saying that we need to get more of a standardized approach where you go in, and I mean, that's what I love about BFR. We talk about it, you go through our course, and I mentioned this, is like, okay, now we're talking about how can we downregulate this thing called myostatin, which is part of the TGF-beta pathway, and TGF-beta pathway is what's involved with fibrosis, and we're trying to downgrade fibrosis to be able to have regenerative stem cells. We go through all this stuff, right? And then you're like, well, how do you do that? And it's like, you push power, and you push the Doppler, and then you hit inflate, and you do the exercise. And it's beautiful because in your mind, you know why you're doing that.
Yeah.
But the treatment is it's not like, well, I think you rotate a little bit, or lay on your side and blow this balloon or whatever.
Yeah.
It's and one of our surgeons said, he's like, this is cool because you can give someone an injection, and it could be vitamin C, it could be antibiotic, it could be a life-saving cancer treatment.
Yeah.
He's like, what we know is that we know, do that injection, our brain, we know smart enough of exactly what it is, but there's no fooling around of like, okay, we got to roll right and do this, and now I'm going to try and put the needle up in here. It's just like, we need to have more things like that in our repertoire that are very standardized. We can do it where it's like, look, this is the best we can do, and this is exactly why we're doing it, and this is scientifically valid, and this is what we're going to do for you, Miss Smith, today, and I hope I helped you with your sarcopenia by giving you the best treatment that science has shown us right now.
Yeah.
Man.
Step your game up.
Yeah.
Count up.
I mean, and I don't. We had a talk with one of our professors, Alan Besselink, and who's over at St. Augustine, and he's constantly saying that a lot of what we do as traditional PTs, traditionally we don't, whether it's manual or general exercise treatment or any other massage, any other modality, there's really not too much research backing up like, this ultrasound works for this reason all the time for this type of patient. And it sounds like blood flow restriction training is like the one thing physiotherapy has to be like boom.
Well, that's something. And again, when I was first doing this, it was with muscle protein synthesis researchers and physiologists and tourniquet researchers. So guys they can look at our stuff and call bullshit. I mean, like I said, they came in and looked at our stuff. They're like, "You guys are fooling yourselves with great. And why is that guy spinning that slow on the bike?" You know?
Yeah.
And so this is a beautiful chance that we have, because we have these smart people's attention, and they're also very interested in this because they're getting funding, and this is something that, I mean, just go, do a PubMed search of the BFR and occlusion therapy type things. There's so many articles coming out that we have a science-based medicine foundation. Because you know what my guys, like my research guys, don't give a rat's ass about? Like scraping or needling, and nothing against it, but there's never going to be the science behind it, because the big publications out of the academic labs that are giving us a science-based foundation, they're not even looking at that, because they're like, whatever, that doesn't make any scientific-based sense. I'm never going to get funded for that. It just doesn't make sense.
Yeah.
These guys are all looking at this. I mean, it's not even like, does it work anymore? It's like, what's the exact mechanism, and how much pressure should you use, and can you turn on MPS immediately once you get it on with minimal exercise. So they're building if you have science-based foundation and then you have an evidence-based foundation that are both going hand in hand, that's undeniable to insurance payers. I mean, try and deny that.
Yeah.
Look, I can turn on MPS with this, and these clinical trials show that these people did better when they did it.
Yeah.
Why aren't you going to pay for that?
Yeah.
Right? So that's my goal, and that was the whole goal with getting this out there and building this, like I said, on this slow foundation. The trials are ongoing. We're already publishing trials. I mean, our knee scope paper, it's low-hanging fruit. Knee scope, it was more to show that we didn't cause clots in people doing it, but they did better on everything.
Yeah.
Strength, they did better on self-reported. They did better on their functional outcomes. They did better on girth, and so we have both of those going hand in hand, and that's a very powerful thing.
Exciting.
Yeah,
I am
super
pumped.
excited. Yeah, I'm pretty pumped
I'm
too.
jazzed again, to reference you. And I know Tyler, I'm kind of going to put you on blast.
Uh-oh.
I've heard you say this a lot of times about worrying if you're going to be able to fix people.
Yeah,
And
super worried.
talking about when you're referencing other therapists, like, does he really fix people though?
Mm-hmm.
And kind of having that being like, I'm the fixer. I get people well, and I think we need to have an intervention for you, sir.
Oh yeah.
And tell you
maybe.
that it might not be as important of a personality to have.
Yeah, I definitely have even written. I've never published it, but I've definitely even written a blog of, like, I want to have magic hands. Like, I want people to come to me, and I want to have a solution, and I don't want it to be I want to see people get. And
You want to be the fixer.
I want to be the fixer. And I actually, we had a meeting last night. I have a certain level of anxiety constantly of, how you feeling? Does it work? Does it, and
Yeah, that can be a recipe for burnout, because what happens if you don't?
yeah.
For one. And so, when you get out of school, you think you can fix everybody. You think, obviously, you hear, everything and all this sort of stuff. And then, us old timers are saying, the longer we've been at it, the more we don't know. It starts to really feel like, and it's just like, man, the body's way more complicated than I ever thought, and now we're learning the mind is way more complicated than we ever thought as well. And you might do things that have fixed someone physiologically or physically, but mentally it's just completely not there, and they're not feeling fixed, and it's like, well, man, how am I working on both those solutions? And so I think, it's a loaded thing to say fix. You can only do as much as you are capable of, right? You can't be the psychiatrist, and you can't be the best therapist, and you can't be the business manager and everything at once, but you can be good at a lot of those, I think. And so, I mean, like I said, there's always, I had a buddy who was very insecure always, that like, man, I just think I bet you would know how to get this person better.
Yeah.
It's like, I'm doing the same thing you would be doing for that person, and it's just, you can't really over worry yourself with that.
It's definitely something I think I need to think about and really try to make a conscious effort towards, because right now, because we're in this flex performance, I get to do I'm a personal trainer, and boy, I recently went to Orange Theory, and I might be saying too much, but one thing I loved about coming to Orange Theory was I stopped doing one-on-one where it was my program, and it's their program. Okay, I believe in Orange Theory. I think it works, and so I
it's a big burden when it's just on you.
Yeah.
I mean, it definitely is, and this person's coming at you, and then especially when someone's in pain and they're having these problems. And I think, again, knowing my fellow therapist was just banging himself over the head because he couldn't get this motion back in this kid's knee. And the kid's, it's fibrosed, you know, and the kid had a big old cyclops lesion, and basically it's like, looked at him like, dude, you're never going to get it back, so stop. You know, just stop. You got to know at this point, let's go, ortho needs to get involved and see what we can do, but this is beyond your scope now. And so that once you start seeing like, hey, we don't got anything for you, I think that's as empowering as I got this for you. And what you got for them, hopefully it's the best and most scientifically and evidence-based as it can be. And then there's some things that don't have to be. And you know, Jerry's stuff with, you know, customer service and compassion, that heals, and that's great. And I think I think therapists are all way too good at that, actually, you know. And we need to be able to do that. But yeah, I mean, know what's the best science and evidence-based treatment, and when you say this just isn't what I can do for you, I fixed you as much as I can do. Is the way to go. And we at CFI, we would have patients sent from all over the world from other, because we're, you know, supposed to be the CFI and all this sort of stuff, and so lots of times we'd have these people come in, they'd lay out everything. Sometimes it was like, oh my God, seriously, that's what they've been doing with you? All right, here, come here. But then sometimes, you know, you'd call and be like, you're right on, man. It's just it. You're not going to get that motion back. Scar one, sorry, or whatever. There's, you know, that nerve is damaged and it hit fibrosis, and they're not ever going to regenerate. And there's nothing you can do. Stop with your e-stim and all this sort of stuff. It ain't going to work. And so, it's tough though. I mean, that's like I said. Our areas in our profession is very gray, and that makes it very hard on clinicians when you've got a lot of gray out there, and it's just like, man, well, should I go do that course because they? I would follow the science. I mean, what's helped me the most is learning physiology on a very deep level, and being around such smart people that have helped me understand the body from that aspect. Because I spent years understanding the functional side and the global aspects of it, and a little bit more of it, but now learning these pathways a lot more makes me question our treatments a whole lot. And then if I'm in a lucky enough place now. If it looks like what we're doing doesn't work, I'm able to get my resources and look for solutions. Which usually involves research.
That was another huge thing for me, hearing Dr. Johnny talk about the research behind it, and when he breaks everything down on a physiological standpoint. You know, it's like you said, it's undeniable. We know these are the mechanisms. This isn't like there's no, I think I'm on this vertebrae, not to diss anybody, but just to compare, we have the physiological mechanisms behind this.
And research makes you, when you do it, it really holds you to task, right? And the way, I've got two parts of this. For one, the way my research is done is I'm not conducting usually the actual treatments or the measurements. I have funding, so we have research coordinators. So I don't want to be messing with it at all. I don't want to be like kind of winking to the patient or like letting them know like I really this is gonna be it, or I'm gonna do this. So I don't. And if they come back and they're like, statistically we got nothing, I'm like, okay, cool, that's good to know. That's one thing I can say this won't work for. Great, that's even more powerful. Because if the patient says, should I try this? I can be like, no, sorry, we've looked at this. If it's enough of a robust trial, it probably isn't going to work, right? The other thing I would say is research doesn't just have to be with the researchers. I don't have a PhD, you know. I've got over $6 million in research funds, and I think it's 11 trials that I'm either heading up or, you know, at least it's AI on. And that all just started from questioning, you know, and going in and track. I would track everything. My limb salvage guys, you know, they would have these big chunks of muscle missing, and we would try treatments, and we were just measuring strength and seeing, did it change it? We would track it. Did it change it? Did it track it? And we had all this data, and one of our researchers was like, you should write that up, publish it. So we wrote up a paper on it. And then we started writing papers to define problems, and then next thing you know, I'm like, well, let's get this little trial going. And then we got a trial going, and then once I showed something I did, I showed a problem. I wrote a paper and said, look, here's a problem that we have. There's not a solution. Then I came and I said, look, we did this little trial, and it looks like there might be a solution. And then it's like, I'm going to write a little grant for this and see. And then they're like, boom, there's, first one came in at $250,000. I'm like, wow, that wasn't that hard. That's crazy, And, it's not, I was a full-time clinician that entire time. And my role was physical therapist. It wasn't researcher. That was just all on the side. And it's doable. It totally is doable. It's a lot of work.
Yeah.
You got to be passionate. I mean, lots of nights, but
Yeah.
it's doable.
There. So I'm thinking we finish it on a high note on talking about the future of
Has it
BFR.
been down notes?
No,
No, all
I'm
right.
still thinking about my fix. I'm trying.
My friend one time said, there's two types of therapists. Okay, let me get the story right. Because one guy said he had two types of notes. He wrote a no and a beta. And if a patient came in and they said they were better, he just wrote a line on the end and said mo beta, or they were no beta. But
Nice.
my other guy said there's two types of therapists. There's a therapist when the patient stops coming to treatment, they just discharge on their own.
Yeah.
That therapist is like, oh man, I must have got them so much better they quit.
Yeah.
The other one, they stop coming, the guy's like, oh, I'm not getting them any
Yeah.
better. They're just stop coming. And so you're gonna run these personalities out there and they're just like, I get everybody, I'm the best. And it's just so like puffing your chest out. And I think being humble and always just a little bit of like, I'm trying as much as I can. I want to keep learning, and that's all you can do. And don't worry about these people that are the ones who are saying they're getting everyone better. Usually aren't the ones that are. They're remembering in their minds those few success stories.
Yeah.
My best job was my first one because I took care of mostly high school athletes and some JUCO, and those little kids got better on their own. I didn't have to do anything, and I was just like, I'm the best. And it was all like sports, and then I took a job in New Orleans, and it was a little bit of an older population mixing with sports, but these older folks, I wasn't getting. I was like, what is wrong with all these people? I can't get them better, man. And, these little stenotic backs.
For some reason, I'm not as good.
Yeah, well, it must be New Orleans. I need to move back to Texas.
Yeah.
That's why I moved back to Texas.
There it is.
Yeah.
What's our BFR high note you wanted?
I was thinking about like what's the future of BFR and a few plugs and things like that, So what do you envision what we're gonna see from BFR in the future, and then where can people find you? You're better about doing.
We're all
plugs,
gonna walk
Jared.
around with tourniquets.
Yeah. Is it? We're just 24/7 tourniquets.
Domination.
Taking over the world. Well, I hope our profession is able to get where we're all standardizing it, and we're using the FDA defines a tourniquet as anything that includes blood flow to a limb, either full or partial occlusion, is an FDA medical device. And so that's important for us to know as a profession. Again, we're trying to be bigger as a profession, that we should follow the right rules. If you go into surgery, the surgeon isn't just going to say, I'm just going to use this little wrapper thing, whatever. It's the same exact rules in a clinic. And for some reason, our profession and a lot of our clinicians are ignoring that, which can be dangerous. So I hope we can get it to where we can standardize it, because that sets up the next thing. Because as we have the science-based foundation and the trials that seem to be going in the right direction, then we lobby to get a code. And once we get a code, then everyone that does it can bill it, and we hope it's a good enough code in this new coding system we have that it pays really well, because we have both science and evidence-based foundations for it. I hope that it does move, and y'all's school is great. My third course I'm going to be doing here with them, that it starts becoming curriculum in school, and that forces people to understand deeper physiology as professors, so that they have to know what the mTOR-C1 pathway is if they're going to talk about exercise. And then from that, we're moving, waiting on medical device clearance in Europe, so we'll be moving into Europe probably next month and start going more of global with this, and really hoping that this kind of redefines what we do in rehab. We get some kind of different respect with some of the other medical professionals.
Nice.
Awesome.
Nice.
Whew. How can people get in contact with you and reach you?
Yeah, so our website is owensrecoveryscience.com. We have blogs on there and media stories and all that sort of stuff. You can also see about courses. My personal Twitter is at Johnny Owens CFI. Facebook, I don't even know what it is. I'm not a good social guy, man. I barely even do it. But yeah, those are probably the best ways.
Awesome.
I've learned more about the boxer Johnny Owen.
Yeah. Who died, right?
It's a pretty tough. Oh, I shouldn't be laughing, but I'm like, search of Johnny. I'm like, who's this boxer? And you research him, you're like, dang, he died in the ring.
He's a famous Welsh boxer, yeah.
Oh, man. So if you guys
Well, forever it was him and then some like realtor in Oklahoma. So I beat the Oklahoma guy.
There you
now,
go.
So I'm just trying to.
Now you gotta
It sounds bad. I don't want to take out the dead boxer, but yeah, I'm coming after you, Johnny Owens from Wells.
And take that,
Yeah.
you Welsh realtor.
All right.
Thank you so much, Johnny.
Thank you so much.
Yeah.
John.
You're the best.
Thank you,
Sorry,
sir.
man. All right, guys.
Thank you.
Yeah.
Definitely.
It's kind of one of those things. It's like the duck. You know, you see a duck in the water, right? The duck looks like it's cool, but the duck's freaking working hard under the water. Wow, working hard, working hard. That's how our place is. We look cool, but we're working hard.